All right. Good afternoon, everyone. It's just past 4 o'clock. People still trickling in, but I think we can get started and start with the introductions. I'm Jacob Kirsch. Uh, Greetings from South Florida to everyone. Hope everybody is doing well in these times of difficulties and challenges in the healthcare environment for sure. Um, and welcome to the NASCI monthly webinar of Curious Cases. Um, as usual, everyone is invited to come and participate and present their cases, share their screen, and comment on everybody else's case. Um, but before we get to that, before we get to the cases, I'm going to close this off here, and I'm going to point you towards the NASCI website. There it is. Just a quick reminder, our virtual annual meeting is coming up very quickly. It's going to be here in less than 2 weeks. We're very, very excited. A lot of work went into putting this meeting together. The program is fantastic. The speakers are great. And usually, as you know, NASCI just provides a very, very warm environment for everyone to come and mingle. So in an attempt to preserve that environment, that warm family-like environment, we took on the challenge of putting additional events together surrounding our educational lectures. And I want everybody to be to join us for those, and everybody is invited. So the first one I want to mention here is the wine tasting. It's a networking event that's going to be Sunday night. This is going to be in lieu of our annual gala dinner. So you have to register for this. The funds will go towards the R&D fund of NASCI. And by registering to this event, you will receive via FedEx. If you live in the U.S. only, you will receive via FedEx 2 bottles of wine. We're going to be joined by a world-renowned sommelier, uh, Allegra Angelo. She is one of the few female sommeliers in the US. And not only that, she is one test away for becoming the only female master sommelier in the US. So she is a fantastic resource. She hand selected the wines. We're going to do what she calls the old world versus new world. So it's a selection of two Pinot Noirs, one from France, one from Washington State, and she's going to walk us through how to do the proper tasting and try to take notice of all the nuances of the differences in the weather that there are, etc. So it should be a lot of fun. It should be very interesting. And right after that, we are going to spend some time talking about all things NASCI and just chatting and catching up with each other. So it should be a lot of fun. Uh, for sure. So try to join us for that. Also, the annual 5K that we put at the regular meeting, at the in-person meeting, well, we're going to do it virtually. So do register. I think if you register right now in the next today and tomorrow, you may still get your running shirt on time for that weekend. If not, doesn't matter. We'll make sure you get it later. But at least you can join us and just do whatever you want to do. You can run, walk, do some yoga, swim, just take some pictures and post them on social media using the hashtag hash NASCI runs. That way, it'll populate our 5K wall in our website. Um, the other event is part of our wellness initiatives is the NASCI virtual yoga. This is going to be Saturday morning before the boot camp. Dr. Purvi Parwani put this together, and she was able to recruit Eddie Stern, which is a world famous yoga teacher, instructor from New York. He's actually an instructor for celebrities, and he was so kind to come and join us during NASCI. So that's also going to be a lot of fun. Try to join us for that. I know it's early for some of the West Coasters, but it should be really, really a lot of fun. And that's going to be right before the boot camp. And just a reminder for all the trainees on the call, boot camp is free this year. That's Saturday 12th, all day long, cardiac imaging boot camp. Try to join us. Tell your friends and your co-residents about it. It should be a lot of fun. Again, register for the meeting. Saturday is a boot camp, which is free, and there's Sunday and Monday is the actual scientific sessions and educational conferences. You have to register for those. And then through the website, you have to register individually for the wine testing, the 5K, and the yoga session. Again, all of them are going to be fantastic. I'm really, really looking forward to seeing you there. And with that, I'm going to close this. And before you look at this, we're going to look at some cases. Before I start showing cases, anybody on the call who wants to show cases, to have something to share with us? If not, I can start. Well, you finish putting something together, but if anybody's ready, we can go ahead and start with you guys. If you're trying to talk, you're probably muted because I muted everyone. So unmute yourself.
I have some cases. It's Carol. I can show them after you or after anyone else.
Okay, fantastic. All right, so let's do that. So I'll start, and then Carol, and then whoever else wants to share some of their interesting cases, if they have questions or quick show and tell us, everything is game. So the first case, I think, is this one. What I have here is number 31, and this is an MRI. I'm going to scroll somewhat slowly. This is close to a short axis, a little bit higher. I'm sorry, a 4-chamber view. And it already looks kind of funny. There's something funny about it. These are axial, steady state, free precession views. Doesn't go much higher than that. I think that would have been helpful. Let's look at these images. So any thoughts on, anybody wants to comment here about this image here? Do we have any trainees on the call that want to try and take a swing at this? The first thing that is very obvious here, to me at least, is this most anterior structure. If we remember, the most anterior structure, anterior and to the right of the aorta, is the RVOT and the pulmonary artery, and clearly this is not it. This is going way up. This looks like the aorta. So the aorta is now anterior position. And if we go back to these axials here, that would be this structure, but at the same time, you see there's this very muscular outflow tract, which usually we see this muscular outflow tract associated with the right ventricle, not the left ventricle. And here, this is a 4-chamber again. And there's a couple of things, but I think we can see where the aorta is coming from very anteriorly from what looks like a morphologic RV with that muscular outflow tract. So this is a transposition of the great arteries. Again, this is a corrected transposition. So 2 wrongs making a right, I would say. And the other thing, what I think in this case is very interesting, and not just your common LTGA. Let's see if we can see it here. Not on this image. Okay, so these are very dark. Let me just lighten them up. Again, this is a 13-year-old male. This is a young kid with congenitally corrected transposition. And again, you can see here the aorta is anterior and to the left of the pulmonic valve and the pulmonary artery. So that's completely abnormal for sure. But what I wanted to show you here, there's an associated finding here. You see this here, this windsock deformity, almost like a finger, right at the level of the interatrial septum. So that's an interatrial septal aneurysm. So it's just a very flimsy membrane of septum that becomes aneurysmal and outpouches to some degree, almost obstructing here the outflow tract into the pulmonary arteries. So just an associated finding in this patient. And these are the short axes. If we can see it here, you can see a little bit of it right there centrally.
Did the patient have a corrected VSD, Jacobo?
Did the patient have a corrected VSD? I not that I recall. Let's see. I don't remember, so I don't think so. I do not think so. I don't see sternotomy wires artifact either, but you know, that doesn't necessarily mean that the patient did not have surgery. But I don't see evidence of a prior sternotomy, but I do not remember that. I don't believe so. You're saying because of this?
No, I was just thinking the members, you know, I didn't know if, because you know how sometimes double outlet RVs are kind of on a continuum with,
Yeah.
you can have PGAs that are actually double outlet RVs, and I didn't know if that's what it was going on and they actually had it corrected.
No. Again, I don't think that was the case, and this was not a double outlet RV, but that's a good thought for sure. Welcome back, Greg. I heard you were out of town. All right.
Yes, back to civilization. Thank you.
Awesome. All right. Next case. Let's see what do we have. I have this case. This is a great case.
Can you hear me?
I can hear you, Dr. Morris.
Oh, sorry. Hey, Jacob, I was going to say one thing. One thing is, when I was a fellow, we had a patient sent in for rule out non-compaction, and it was actually transposition. So I have seen that one time where it was just missed entirely, and not till they came to MR was it realized it wasn't actually non-compaction. It was just the hypertraveculated right ventricle that was in the wrong place.
That's kind of insane, actually, if you think about it, that it went unnoticed. How old was the patient? You remember?
He was a young man, so in his 20s.
Got it. That's interesting. That's kind of crazy. All right. So this patient, let me see. This patient is a 67-year-old female. This is a very interesting case. So she came from an outside provider with a diagnosis of right atrial mass on echo. I tried to get a copy of the echo, could not find it. So came over and we did an MR on her because that's what they wanted to use for the mass. And it's a very reasonable approach for sure. So we had this report. It was a large mass, so in theory, we should not have missed it. And let's see what we have here. So I want to make sure that I show you the right images. Let's look at the black blood first. Axials through the chest. And you can definitely see there's something there protruding into the right atrium, right there. It seems like there's maybe a little bit of a fat plane around it there. So is it intracardiac or just outside and pushing in? At this point, who knows? Same here, maybe a tiny fat plane lateral to it, left lateral. And let's look at, it's a nice black blood double IR, so no fat saturating here, but usually really good images. And you have two images, and you actually see here the left main and part of the circ, the RCA, and then you have this structure, and it definitely looks like it's outside the heart. You definitely see a plane here, and in here, it seems to be in continuation here with this signal nulling or no signal from the void created by the flowing blood in the coronary. Let's see what else adds to this. So it's a 4-chamber. And again, doesn't really add that much. We have perfusion, and then we have post. And you can see that mass, and now you actually do see that there is some contrast going in the center, kind of channeling through that big mass, and where we thought it was in continuation with the coronary artery. And this is your late enhancement. This is an oblique sagittal here. And again, you see there's no signal coming out of that mass, and again, some contrast within it. Any thoughts so far? What does this look like?
Looks like an RCA aneurysm,
Yes, it does.
partially thrombosed. I had a exact similar case before I came here. Same history, mass, same location. Yeah, no, and it was also partially thrombosed, just like this.
Let's see.
Yeah, I've seen cases like this, although that symmetric thrombus formation is a little
Yeah, it's weird.
odd. I've seen cases that have ended up being sarcomas. Oh, that looks like an aneurysm when you go through it there. And that doesn't look quite as symmetric. So yeah, that looks much better for aneurysm.
Yeah, you're right. But these are thick MIPS. If we look at it looks pretty central and symmetric. I think that you are correct on that. Let's look at it here. So I think that pretty much it matches great that black blood sequence that we saw on MR. So this is a thrombosed aneurysm or partially thrombosed aneurysm of the RCA. That's pretty dramatic. I'm kind of upset that I never got a chance to look at the echo just to kind of complete the case for presentation. But I can totally understand why it would look funny and definitely like a mass or a paracardiac mass on echo that would warrant further imaging. All right, so that's a acute aneurysm. And again, this is an older patient, fair amount of plaque. So this is related to atherosclerosis, most likely, right? Which is the #1 cause of coronary aneurysms in the developed nations. Let's see, case 46. So this is a very interesting case. We don't really see this that much. It's an older case, but it's definitely worth looking at. This is a pulmonary isolation case, so it's a patient underwent. This is not pre-PVI. This is post. This was a follow-up. So let's see what you guys think. I think you're gonna get a lot of the findings very quickly. And this is a 53-year-old male against post-isolation. So we see here the superior left pulmonary vein, and there's a stent in there. I think that's pretty obvious. We see the inferior looks fine, and then we see the right superior there with a stent, very widely patent. And then we see another stent here on the inferior, but it's completely thrombosed. So didn't really do what it was supposed to do there. So we have stents in 3 out of the 4. One of them is thrombosed. The left inferior pulmonary vein doesn't look too terrible. Maybe there's a tiny little bit of a waste here. So I would have doubted that they tried to put a stent in that position. Let's look at it in the coronal plane. I mean, some of you probably have seen this before, but there's the thrombosed again on the left. Yes, you can see a bit of a waste and maybe a bit of a membrane there, but the enhancement seems very similar to that of the atrium. So what's really interesting here, and I have not seen it since, is I want to see which, maybe this one is a better one. No. All right, so it's going to be here on the axials, and then we can do some recons if needed. So I told you there were stents in 3 out of 4. So what happened to that? Actually, there may be another tiny little one here. They were trying to selectively get another one of those branches. But then if you pay attention, right here underneath the mitral valve, stuck between the leaflet and the septum, there's another stent that dislodged and migrated and got stuck in there. So they did try to place another stent. I don't know in which position. Maybe it was in one of the other ones and they noticed immediately and they replaced it. I doubt it, because they would have tried to snare this out. So it was probably that on the inferior left pulmonary vein that got dislodged after placement. They didn't realize during the procedure and just came to be noticed in these post images. Let's see what it looks like on the coronal. So there they are, those ones. And then we go into the heart and you can see it right here, stuck between the mitral valve leaflet and the septum. So a migrated pulmonary venous stent. Again, pulmonary vein stenosis, it's a known complication of pulmonary vein isolation. We don't see it very often now, because now with new techniques and more experienced operators, they do not go into the pulmonary veins for the ablation procedure. They ablate really in the left atrium around the ostia, over the pulmonary vein drains. So that scar tissue that used to occur in the past, like in this case, we rarely see it nowadays. So these are not that common. And treatment for those stenosis, when significant, was to try and go and stent those cases like they did here. All right, that's one other case. And I have just 2 quick cases here, kind of companion cases. Because again, one of them we still see time to time, the other one we don't see as often. So let's start with this one, 52. This is a patient with hypertrophic obstructive cardiomyopathy. It's going a bit too fast. The patient's not that hyperdynamic. So that's a short axis. Let's look at the LVOT or 3-chamber view. Doesn't look like a 3-chamber view. Let's see if it rotates. Yeah, so it's a rotating image. So this is your outflow track, and you can see here your 3-chamber view. There's near complete obliteration in systole of the chamber, but you can definitely see here that they cut out part of the septum there at the LVOT. So this patient underwent a septal myectomy, a surgical myectomy. So there's the sternotomy wires, there's a clips in the aorta. Usually what they do is they come from above, they open the aorta, they put their scalpel down past the valves and kind of just in a circular motion scoop some of that muscle out. And that creates significant relief of that obstructive pathophysiology. This patient now has turbulent flow coming from the mid-ventricular obstruction. So they cut all of this out. So now the area of obstruction is here at mid-ventricle. And you can see that jet of susceptibility, or not susceptibility, but defacing artifact due to turbulence and high velocities originating from that mid-ventricular level. So this myectomy case, we still see myectomy cases. But what I don't see that often is what used to be a good alternative, case 35 here. And this is another MRI. And let's look at this. It's an ugly image. I don't have a 3-chamber. This is all I have. So again, you see some thickening. There's some obliteration of the lumen during systole at mid and distal ventricle. And there's some insufficiency of both the mitral valve, you see the jet there, and the tricuspid valve. And what's interesting is when you look at your late enhancement images, you see this area, this very focal area here, again, at the base of the interventricular septum, the muscular part of persistent gut enhancement, but with central microvascular obstruction, so some really dark signal surrounded by diet persistent enhancement. So this patient underwent septal myectomy by alcohol ablation. So what they do here, they go in with the catheter, they super select the first interventricular branch septal perforator from the LAD. They occlude it proximally with a balloon, so there's no reflux of alcohol, and they inject alcohol and basically give the patient a heart attack. That's very focal, very controlled in that area. And after the myocardial necrosis ensues, then there's thinning of the myocardium, which basically works the same way as we saw on the other patient with the myectomy. You're just thinning the myocardium and relieving that obstruction at the LVOT, and that gives quite a relief of the symptoms to the patient. So 2 cases of treated hypertrophic obstructive cardiomyopathy, 1 through surgical myectomy, 1 through alcohol ablation. All right, those are the cases that I had prepared. I'm going to have Carol now share his screen. So Carol, I'm making you presenter. There you go. We can see your screen.
Awesome. Okay.
You see, you guys make me look so bad. We
Oh.
prepare like PowerPoints and everything. You're so professional.
Well, you have the ability to window and reconstruct, so I'm just always afraid I won't be able to pick out of the 150 MRI sequences that were done, which one is the pertinent one. So the first case is a 51-year-old woman, and if you know the diagnosis based on her mutation, then kudos to you, because that was, I had no idea. So she has a succinate dehydrogenase subunit 8 mutation. Does anyone know what that leads to? Good. All right, so she'd had prior surgery to remove a tumor in her neck, and she presented with a local recurrence, and she had a nuclear medicine study that questioned something adjacent to or involving the right atrium. So she had an MRI, and I'm just showing the pertinent images here. There was nothing abutting the right atrium or involving the right atrium, but what you can appreciate is a soft tissue lesion here between the ascending aorta and the pulmonary outflow tract. And we're just going through it here. And T1 and T2 weighted images, really kind of iso intense with muscle, a little bit hyper intense on T2 weighted imaging. And I'll just stop these guys. And she had perfusion imaging, and you can see that this lesion is extremely vascular, lighting up like a light bulb on dynamic perfusion, and also a lot of enhancement on late GAD. She also had a coronary angiogram, and you can see the extremely vascular nature with this large vessel coming off the right coronary artery and perfusing this lesion. So just to ensure that there was no metastatic disease anywhere from this, she had a CT. And I think you can appreciate here at the base of the neck, there's also another enhancing lesion that's kind of pushing the vessels away. So very well defined, similar to the other lesion on MR, quite well defined, but very vascular. And as we move inferiorly, we can see the lesion that was identified on the MR. Again, very, very vascular, really just pushing, has pushing margins, not infiltrative, but there's a lot of collateral vessels around this lesion. And this might have been what they saw adjacent to the right atrium on the nuclear medicine study. So you may have seen this type of thing before. Does anyone know what this could be? So this is a paraganglioma, and this is her recurrence of her glomus tumor at the just in the jugular foramen, extending into the base of the cerebellum. And so these are multiple paragangliomas, and so apparently this mutation results in the development of multiple paragangliomas. So the paragangliomas can be intrapericardial. They're rare tumors of chromatin cells arising from an extraadrenal location, and they tend to be located in the aortopulmonary groove close to the left atrium at the level of the paraortic sympathetic ganglia. And patients can be symptomatic if they're functioning, so they can present with catecholamine hypersecretion, so hypertension, palpitations, headache, and sweating, or due to a mass effect on the adjacent structures. But if they're non-functioning, they can be incidental findings. And hers are non-functioning. And so the differential would be hemangioma, sarcoma, but we can see this was really quite a well-defined lesion, wasn't invasive in appearance, and then metastases. And I just have a couple of companion cases. So this 38-year-old man, he did present with night sweats, non-productive cough, weight loss, and he had elevated metanephrines and norepinephrine in his 24-hour urine collection. This is a still image from an echo, which showed a very vascular mass on Doppler. Just in the region of the main pulmonary artery and ascending aorta at the root. This is an older case, so you can see the ascending aorta here, the main pulmonary artery, and this soft tissue mass, again, quite well defined. Angio, they were able to do a selective injection. This was coming off the left coronary artery, and you can see again a very vascular lesion. And cardiac CT, you can see a lot of vessels around the paratracheal regions, and as you move down, we can see this mass again, which looks very similar to our other case. Well-defined, kind of pushing things, doesn't look invasive, but is very vascular, a lot of collateral vessels around this lesion, which is intrapericardial. Calcification of the aortic valve, which I think he had a bicuspid aortic valve. And So treatment for this is resection. So he did have this removed, and he's been lost to follow-up since. So just some images of the lesion and coronal oblique reconstruction. You can see the left coronary artery coursing through the mass which surrounds the left coronary artery. So it must have been really tricky to resect this. And another companion case, this is an older individual, incidentally noted, hard to believe. So he's got a very large mass, again, very vascular. Here we see perhaps some central necrosis. And it's in the same location in the aortopulmonary groove. So all three had a TAVI. All three patients have a similar appearing mass, similar location, different size. So any questions on that?
Those are great. That one looks really ugly, but those are great.
Yes, I know, but it's hard to believe that it's benign, really. Okay, here's a second case. 66-year-old woman with paroxysmal atrial fibrillation. She'd had a secundum ASD repair as a child. So on the left is a balanced SSFP, on the right is a gradient echo. It was on a 3T, so we were having trouble getting a nice SSFP. So you can see she did have pulmonary hypertension on echo and right heart cath. So the right ventricle is dilated and hypertrophied. You can see the atria are dilated, and there's something a little bit strange looking about that left atrium. There's the left atrium, this very large thing here, and then there's something underneath as well that is also quite dilated. And you can see a dephasing jet through this area here. So it almost looks like she has 3 atria here, and this is quite a typical appearance for a core triatriatum. So that stands actually for 3 atria. And this is a core triatriatum sinistre because it's on the left, which is much more common than a core triatriatum dextrum, which is a duplicated or right atrium. So this is quite rare. It can be a intact membrane separating the chamber where the pulmonary veins come in. Or it can have some fenestrations or like a funnel-like connection. So it can cause varying degrees of obstruction depending on how big the communication is between the posterior aspect of that left atrium and the anterior chamber that receives the blood from the pulmonary veins. So this patient, the connection was actually, oh, I feel like my PowerPoint is crashing. Yep. See, that's the advantage of for you, Jacobo.
No, my thing also crashes. Oh.
Your Osirix. Okay, let's try opening again. All right. So everybody, I'm sure you're aware. So she went to surgery. She had actually it was a 15 millimeter opening between the posterior chamber and the anterior chamber. So it was a reasonable size, and on right heart cath there wasn't much of a gradient between the posterior chamber and the anterior chamber. But she does have quite severe pulmonary hypertension. So getting there to my...
While you're looking, let me ask you a quick question. On that two-chamber view, on that oblique sagittal on the right of the screen, underneath the left atrium, was that just the aorta that was coursing below the heart because it's tortuous, or is that a very big coronary sinus?
That's a really good question, Jacobo. That was a big, huge coronary sinus. Do you know why?
Well, I can guess. Is it on roof?
Well, it could be. There are, usually these patients have associated, can you see my screen still?
Yes.
Yes.
Yeah, okay. So usually these patients have other congenital abnormalities. So she'd had an ASD repaired as a child, but many other anomalies can exist, including a persistent left SVC.
Nice.
And unroofed coronary sinus, but she has a persistent left SVC, as you can see here, but did not have unroofing of her coronary sinus. And so you can see here the core triatriatum, so quite a big connection. Yeah, so rare. People have usually other anomalies. And just a vibe here, post-contrast, she also had interruption of her IVC and azygous drainage. So her hepatic veins drain directly into her RA, and you can see the dilated azygous and hemiazygous veins here. And then, of course, the left SVC, so other venous anomalies. My last case is something I saw yesterday, and actually, I need your help. So I thought I'd show you this. Lots of people are away on holidays this week, so I wanted to kind of show it to other people to see what they thought. And so this guy, 60-year-old man with paroxysmal atrial fibrillation, mild concentric LVH on echo, and he'd had like ECGs dating back several years, and they all suggested HCM. So big QRS complex inverted T waves in the precordial leads. And this was his MR. His EF was just borderline low. His left ventricle is dilated minimally, and his LV thickness was about 16 in the septum. So not hyperdynamic. There's some mitral regurgitation, a little bit of tricuspid regurgitation as well. And perfusion was normal. He'd had a coronary CT as well as an angiogram and no significant coronary artery stenosis. And these are the LGE images. So you've got, I mean, the wall motion to me was pretty normal, maybe a little globally hypokinetic. I don't know if you agree. There was no focal hypokinesis, and the LGE is subendocardial at the apex and anterior wall. There's also LGE in the posterolateral wall. So my thought was that this was likely a burnt out HCM, but I would really love your opinion.
Carol, do you think it's possible that he just has apical variant HCM?
That's what that it's not burnt out because it wasn't really thick at the apex.
Yeah, I guess, but I was impressed by it seemed a little hyperdynamic at the apex. That's the only reason why I was wondering about that.
Okay, well, it certainly has that you know, I was looking at the T waves, and most of the enhancement is at the apex, and it has that apical HCM kind of enhancement look to it. But the EF is low normal, and the ventricle is mildly dilated.
Were there any were the papillary muscles abnormal, or were there any myocardial crypts? I didn't see any, but I don't know about
Crypts. Yeah, and I didn't notice any abnormalities of the mitral valve apparatus.
or even sometimes you'll just see apical displacement of the papillary muscles or accessory papillary muscles.
Yeah, I didn't.
They look fine on the short axis. If anything, you have a bifid posterior pap, but otherwise they look okay there.
Mm-hmm. So I'll probably just stick with HCM, but it may be on its way to getting a bit burnt out because it is not really thick, so it's probably thinning out. And
Carol, what was the?
How old is the patient again? Oh, sorry.
No, I was
60.
going to ask about clinical presentation. So yes, age and
He's got AFib,
how old?
60.
Any chance that this is something else, either sarcoid that's, you know, just primary to the myocardium, or even Chagas disease? Because with Chagas, I've seen Chagas with that pattern of enhancement. Actually, it's relatively common in that posterolateral base of the heart.
Yeah, that's a good thought, Jacobo. Maybe I'll include that. And yeah, definitely sarcoid could give that appearance. Maybe I'll suggest a PET CT.
Do you know if he's a hypertensive?
He is. He's also 340 pounds, has type 2 diabetes.
Okay, so then, you know, a little bit of LVH could just be part of his hypertension, and that the enhancement is some other disease process.
Yeah.
Interesting. And otherwise, no evidence of myocardial damage, right? No troponins or anything else to suggest this could be a myocarditis or drug-related or something like that.
No, nothing else.
Hmm.
Yeah. Okay, well, thanks, guys. I'll probably add Chagas, but thanks for your input.
Yeah, keep it
That's
posted.
all.
Perfect. Thank you. All right, Mike, I think you can. I shared the screen with you. There you go.
Can you hear me now? Sorry about that.
Yes.
Okay, sorry. So let me just move a couple of these things off the screen. So I prepared just one quick case. It's not really a diagnostic dilemma. It's just more of a cautionary tale, if you will. So this is a 65-year-old male who had a history of rheumatic heart disease and had both bioprosthetic AVR, and then that was followed by a mitral valve replacement. And also, not surprisingly, because of his mitral disease, he had developed AFib, for which he was on amiodarone, but not anticoagulation. And he presented back to his primary cardiologist about 11 years after his mitral valve replacement with recurrent heart failure symptoms. And as you can see here, they did an echo and his gradient was 14. So anything over 10 and above is consistent with severe mitral stenosis. And his EF was okay. The surgeons weren't really interested in trying to fix that because this would be a third reduced sternotomy. So he was instead referred to the structural team for consideration for transcatheter mitral valve replacement, or TMVR, and you can see here his STS score. So he was otherwise in pretty good shape. And I don't have his initial echo, transthoracic echo, where they diagnosed the mitral stenosis. That was done on the outside. But then he came to our attention with this CT scan, which was done for TMVR planning. And here's the axial views of the cardiac CT, and you can see here he's got a dilated left atrium. Here's the MVR, left ventricle. The right-sided system is not opacified, and then if you saw something coming into play here, you can see that here in the posterior wall of the left atrium, there's this hypoenhancing mass that's sort of broad-based and adherent to the wall, like I said, posteriorly and somewhat inferiorly of the left atrium. So the question is, what is that? So our protocol for transcatheter mitral valve, similar to TAVR, is we do a calcium score first, and this is the arterial phase, and then we have a Siemens scanner, so then we do an immediate flash chest, abdomen, pelvis scan. So these two scans are about 15 seconds apart. And you can see here, I just put ROIs, and you can't really tell where the mass is on the calcium score, but based on the distance from the spine, it's about the same. Sorry for the difference in the magnifications, but for the most part, the mass isn't really enhancing, at least on the early arterial or the slightly more delayed arterial phase. But still the question remains, is this thrombus or is this a myxoma? It wouldn't be a typical appearance for a myxoma. So we go on, and if you notice, by the way, down here, let me play this for a second. If you look at the posterior, there's a little bit of calcification here posteriorly in the wall of the left atrium. I don't know if you can see that right in here. So it turns out that he did have a CT 1 month prior, interestingly enough, a PE study at a different hospital within the network. So we were able to see that, and this mass had gotten bigger in 1 month. And so this is just selected images, and on the cines you could tell a little bit more clearly, but it's clear, it is definitely larger from a month prior. So so we let them know that there was something there, and here's just the TMVR measurements that we do. This patient, because he had a mitral prosthesis in place, even though his neo-LVOT is small, 1.3, so general threshold around 1.7 or 1.8 would be the lower limit to avoid risk of outflow obstruction. But because he has an MVR in place, you're not really as concerned about obstruction of flow. But here's just a virtual 29 millimeter prosthesis that fits nicely within the ring, and it doesn't go beyond the post. So as long as you don't go beyond the post, you really don't have to worry about LVOT obstruction in patients who have mitral valve replacement already or mitral valve prosthesis. So that was conveyed to the ordering provider, and here you can see this thrombus sitting here. It's a 3-chamber view, that there was something there, but for various reasons, some of which aren't entirely clear to me, through a series of events, the person who ended up doing the TMVR was not the same person who ordered this study and who got the results. And so the next thing that I heard about was that the patient underwent the TMVR procedure. And so here's images from the cath lab, and these are the TE images after the TMVR was placed. So they put in a 29 millimeter sapien valve in the mitral position. And the valve is functioning normally. There's good flow through it. It's good hemodynamics. But what was not appreciated at the time, but only in retrospect, is you can see there's this hypoechoic area here, actually on both sides of the prosthesis, but really along this side especially, that's kind of creeping up towards the valve leaflets. but the patient was doing fine. And so they did the TMVR, everything was great. And he went to the PACU, and then he coded in the PACU. And so immediately after his code, they brought him back to the hybrid OR and put him on bypass, and then did a TEE. And this is the TEE, and you can see now that there's this there's hypoechoic or mixed echogenicity mass that's bouncing back and forth, and these are the leaflets of the sapien valve in the mitral position, and it's intermittently obstructing flow out of the left atrium. It's intermittently obstructing flow from the left atrium to the left ventricle. This is just a 3D image showing you the size of the mass. So that was a problem, but how to fix it now? Again, the patient had, he was a third reduced. It would be to go in surgically and repair this was potentially a third reduced sternotomy. So instead they tried a transcatheter approach. And this was in combination with both cardiology and radiology. And they went in with an angiovac catheter, went a transeptal approach. And here's the catheter here, and they're trying to suck out this clot. And they were partially successful. So they managed to suck out about half the clot. But then, as you can see, what happened is the remainder started to fragment. So then they stopped because they were worried about just causing an embolic shower. But they still had this little piece they couldn't quite get off. It was adherent to the base of the mitral valve, to the native valve, by a thin stalk, but they weren't quite able to reach that to pull it out. So they stopped, but they felt like, well, we got at least half the clot out, and they sent the patient to the ICU, and he was actually doing okay. He had some sequelae of shock from his arrest, but was still alive, intubated. The next day they repeated the echo, and this is the echo the following day, and unfortunately the thrombus not only was there, but looked like it had gotten worse. At that point, they didn't really feel like there was a lot of options. Surgery declined to operate, and he unfortunately died several hours later he went into code arrest, presumably from outflow obstruction. So anyway, just an interesting thing. Hopefully you never see it, but interesting what happened here with the clot and why people make a big deal about this left atrial clot. That, in this case, initially the clot was actually far removed from the annulus, but in the process of manipulating the catheters, this was dislodged and migrated down and became stuck here at the annulus, and unfortunately led to a very poor outcome. So just a unfortunate but interesting case.
Yep.
Any questions or comments? I think we're almost out of time, but.
That's a great case.
Very interesting.
Yeah, so hopefully you never see it, but now you've seen it. Yeah.
All right, guys. So yes, Mike, you're right. It's 5 o'clock. So if you had any cases ready, keep them on your computer. We'll make sure that you present first next time around. Again, make sure to register for the upcoming NASCI meeting and all the activities that we talked about earlier at the beginning of the webinar. Looking forward to seeing you guys on a screen near you very soon, okay? Take care, stay well. Thank you all.
Thank you. Bye.
Thank you very much. Thank you.